Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are three categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are three things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive two-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
All right, hello and welcome to session 2, day 2 of PerfWeb 26. This is now our 27th webinar because we didn't count a number for the New Orleans conference. So, but many of them are multi-day. So I don't know exactly what broadcast this is, but please, by the end of the show, we're going to try to find out what it is. But I think it's probably close to 60.
I believe so.
And then yesterday was a great day. I don't know how many people were watching that are watching today watched yesterday, but that was so incredibly ironic that we're doing a webinar on angiovac, and there's an emergency angiovac case when the webinar is about to start. And two of the faculty, I get to go and have fun, which I had a lot of fun. And one of our faculty, Dr. Matoyer, it's his case. So he's there with this big, giant thrombus in the right. It was huge. It was. Do you still have that picture? Can you show that picture? You guys got to see what we did yesterday. It was incredible. I know today is about goal-directed therapy, but you got to see this. Would it be hard to do, or is it? If it takes too long, don't worry about it.
It would take a few minutes.
Okay, don't worry about it. I'll show it to you later.
Yeah, we'll get back to it.
Yeah, after the break. Yeah. So anyway, okay. So what do I need to tell them about? I need to tell them about Facebook. You got to like us on Facebook. You have to like us and share. Is that right? Like us and share on Facebook. You have to subscribe on YouTube and click the bell for notifications. Please do that. There it is. There's an example of that. And then you also have to do something, like us and follow us and share us on the Twitter. And also, please also follow us on our new LinkedIn account. And there's that symbol there, okay? So I don't understand all this social media stuff. I understand you got to like, share, follow, share, notifications, LinkedIn, Facebook, Twitter, YouTube, LinkedIn. Okay, our call-in number. There it is. All right. And this is going to be an interesting day today, okay? I'm going to do my best to make it through this. And also, so there's our call-in number. Join our faculty as well. Look, we want to see you on this. You see it right there? You see it scrolling? We need you to join our faculty. If you're, look, John, can put the camera on John. John, you joined our faculty much in the same way, right? I called you up and I said, or you called me up and said, hey, I've got some really good information, good knowledge. I enjoy this kind of stuff. I love teaching. We talked for a little while. You came and did our first program a couple of months ago. It was great. And how come it's on me? Put it on there you go, John. There you are. And that looks a lot better. You are such a dapper looking man. So, but that's how that all happened. If you would tell folks, what the process is and what your experience has been, if you would.
Well, I didn't really know what you had all going on here about 8-9 months ago, and I started finding you online and watching the programs, which are fabulous because they're free. You only have to pay if you want the CEUs, and if you want to just come on and learn, you can play them back, you can find topics and go back from when you started now and watch things that you can rewatch them at your leisure. And I had been working on some ideas, so I just gave you a call. I don't even think you knew who I was. I gave you a call.
No, I'd never met you before.
About 8 or 9 months ago, and I said, Joe, you're looking for speakers, you're looking for topics, and it says that on your site. We're looking for people and ideas. So that's how it started. And you said, love to have you come up, and that's what happened. And we came up and started doing them. And I think this is going to be my 6th or 7th talk in the last 4 or 5 months.
Exactly. So yeah, that's good. Okay, so there you go. The guys are there. So let's just go to a wide shot, guys. I think that just is best. Let's get everybody involved in this, okay, instead of just 2 people. And we've these 2 great folks. So you've all know John. Over on the end over there, you see Rodell. He is our bow tie expert, and he's been on several of our programs. Great guy, great perfusionist. He's got 20 years experience. Came out of THI, just an all-around, very well versed. Overall clinician and practitioner, and somebody that I really enjoy working with a lot. And you've taught me a lot too, which I've really appreciated quite a bit. And then sitting right next to me, you all know Tammy. She was here yesterday, Tammy Sparacino. She's another 20-plus year perfusionist. Great, incredible skills. Came out of THI as well. Work predominantly in community-based settings, which is sort of the foundation, of our thing here. Our webinars are really a lot less about meta-analyses and more about practical clinical experience. And I think that's what's lacking a lot of times when you go to these big meetings. They talk a lot about stuff that is very academic, and I think it's important, but how do you translate all of that into practical application? And that's sort of always been my direction, I guess, that I've always gone. What's your experience been?
Well, I think going to these bigger meetings is a good experience, and you can learn a lot of things. You may even learn about topics that you've never thought of, but you're right, if there's no application on how you can put it into practice, then you're just merely learning for the academic of it.
I agree. Rodell, what's your experience?
So-
like, what's your experience with this whole program that we're doing, and what would you recommend to people? You know how I feel.
Yeah. Oh, I know
You
exactly how you feel.
That that live programs
Yeah.
in person are important for this kind of collegiality, because everybody that's out there watching this program should experience that. So I do think that conferences on site are important for collaboration, but we have a limitation, time, money, all these things that are an influence. You still have to be educated. So I didn't mean to step on you, but what's your experience?
No. I mean, when you presented this to me like a couple years ago when I first started, I said, this is one of the greatest ideas. There is no one else doing this. I mean, if there is, it's severely lacking. You actually put the time and the investment into this. It's very evidence-based practice. I love it, and that's what I'm all about. I'm all about the results. You know, I'm not just, you know, in the OR to, you know, just hang on, turn rheostats, you know, or that type of thing. I want complete patient care. I want to see him in the OR and all the way to home, or where they have to go. I mean, and this is great. I mean, this collaboration is great. I mean, I've heard from a couple of my colleagues saying like, hey, how do I get on? Hey, what do I need to do to do these things?
Why haven't they called me?
They have, actually. There's been a couple. You remember my buddy John at Ohio State?
Yeah, okay, but why aren't they calling and joining our resident faculty? That's what I want them to do.
Well, you know, now that it's becoming a thing or a bigger thing, you know, maybe they
It
will.
took 60 broadcasts.
It
at
took
least
60
to
broadcasts.
get to be a thing.
You have to
Yeah,
trend.
they have
Well-
to trend. You have to trend out there.
Absolutely.
But you know,
Well,
it's
oh, we're trending.
yeah, we are trending.
I like that. It's a new
Yeah.
term. We're trending on Twitter.
Yes, but you know, like I said, you know, a couple years ago when you presented this, I thought it was the greatest thing. You and I talked about it.
You did.
We had a nice conversation about it. You know, there is a younger generation that won't go to conferences, and you know, I go to conferences only because that's what I knew. That's what I started out with, and yeah, they get into some minutia, and you know, you take what you know you want to get out of it, but a lot of it is really just sometimes peacocking. You know, and I don't care for that. I mean, peacocking is great, and you know, they have some great information, but how can I take that to my practice? I don't need that.
Well, yeah, and I don't like to say, you know, I mean, I think that's fair. I mean, you know, I guess my view is that I think I think there are some great conferences out there, and I enjoy going to really good conferences. I really enjoy the collaboration. But I also think that there will be others. I don't think there's anybody doing live webinars like this on such a routine basis that I'm aware of, other than us at this point in time. I think others will, because I frankly just think that's going to be the trend in how we become educated.
Well, don't you think too that it has to do with, instead of doing your conference every year and a half or so, now you can do your conference and you can also learn in between that time with the webinars.
Yes, absolutely. I think that's very true.
Right.
And I think that, yes, that's a very good point. And I think, too, that having these programs readily available, they're free. We all know that. I tell people that all the time. I try not to perhaps say it so often that it becomes gratuitous, but it's a sincere feeling that I have, is that all of us have experience, and the best way for us to contribute back to our profession has been good to all of us. All of us are pretty senior sitting at this table. We've all been around for a while, and I'm sure there's some senior people out there that are either watching us now or will watch us later when they watch the program in whatever way they do. But there's also a lot of young folks out there.
Right.
And, you know, they're looking for people like us who have all of this experience. I mean, sitting at this table is 20, 40, over 100 years of experience. This is over 100 years worth of clinical experience combined.
Right.
That's a lot of years.
Joe, I would add something too. I found different. One of the reasons I called you, how many times have all of us been to a meeting and you go there for 2-3 days and you come back on Monday and you don't do anything different than when you left on Friday? And you learned a lot of academic things and it was interesting and educational, but you came right back to doing the same thing. I found with this way you do this with the panel discussions after somebody presents, most of the time I'm able to take something back that I could actually do different. I think that's really the key. You can go to conferences and conferences year after year and you come back and how many times have you actually said, oh, I'm going to now do this different. I was doing something less than favorable or wrong. Almost never. You've probably had that experience.
Don't you think, too, it's the casual nature that you've set up here,
Right.
that it's less formal, so people can just have regular discussions. You don't, sometimes it's difficult when you go to larger conferences.
Right.
There's the pressure of everyone's listening to the question and all that kind of thing. Even when they have those little roundtable discussions afterwards,
Right.
they know they're in a big audience and it has more of a formal feel.
I have to tell you, this is probably the funniest thing that has ever happened to me at a conference.
Okay.
It was last year at what was our final, the New Orleans conference, okay, in New Orleans. And I received a question on YouTube chat. And it took a while to finally figure out that the person who asked the question on YouTube chat was actually physically in the audience.
Oh my.
Yeah.
They didn't want to come to the mic?
They
Yeah.
didn't want to come to the mic. And I think that's something that we're experiencing here too with
Right.
when we open the phone lines.
Yeah.
People don't want to say it. They're uncomfortable with it. I guess it's a human trait. I've never been. I mean,
Right.
it's my nature is to be rather outgoing and gregarious and unafraid of sounding dumb. But I think that a lot of people have that. They have a great question. They're actually really, really bright.
Right.
But they're still afraid to ask something that others might
Already know.
or look down upon.
Yeah.
Right.
Well, here's the thing. I've been to conferences where a question is posed and then someone else in the audience answers and just punishes them for asking the
Yes.
question. I've been there and I go, wait a minute. I thought this was a collaborative effort. This is
And
this
that
is for
bothers
education,
me.
and that really bothered me.
That bothers me
And
too.
I was a young perfusionist, and that kind of scarred me. I don't want to go up to the mic because there's a senior perfusionist that may come up who's delved deep in academia, and I know that this person is. I won't share it, but
I know who it is too.
yeah. So they just buried the person and just embarrassed that professional, a colleague,
And that's terrible.
and that's terrible.
That's terrible.
Well, the good thing about what you're doing here, Joe, is that they can send you a chat or an email.
Yes.
And they don't
I
have
even
to.
have difficulty
And
getting people to
yeah,
send chat,
they don't do
but
that
what
as much either. But at
but
least
what
you
I've-
could send your question in
Yeah.
without having to be live on the air. And
But what I've heard in talking to Magic, because it's always bothered me, and I never really understood it. So YouTube is not really a very strong live platform. That people go to YouTube, type in a search to look for something, and they watch it. So our post-produced or historical stuff on YouTube is watched a lot. Our live programs are watched the most of all, believe it or not, Twitter.
Really?
Oh, really?
That has
Oh.
our highest level
Really?
of live watching because they get a notification, PerfWeb
Yeah.
is live,
Yeah.
and they just have their phone and turn it on, and there it
Yeah.
is, and they can watch it. And Facebook. Facebook is second, Twitter's first, Facebook second, and then YouTube. Is that correct, Magic?
Yeah.
I have that right. And then, I think that's part of the problem too, is that the chat feature is available on YouTube. I monitor it, but not that many people use it because that's really pretty low as far as people who watch it live,
Interesting.
which I thought was interesting too. And I had that explained to me by the technical gurus over there. Okay, are we ready to go ahead and get my talk going?
Yes.
Okay, so my talk is going to be on early goal-directed therapy and DO2. And these are tied together. And look, I'll just tell you up front that I really got into goal-directed therapy for sepsis back in the early 2000s, about 2003, when I started getting really involved in CRRT, and I started getting involved in, which is a great therapeutic modality for those patients, especially when they do have acute renal failure, but you can use it also just for maintaining homeostatic neutrality. I mean, for homeostasis, it's very, very, very good. But also, looking at other methodologies for measuring cardiac output and indirectly measuring DO2, because a lot of the work, and I'm going to talk about Shoemaker, but there's been others. I don't mention anything from Dr. Rivers, but he came after Shoemaker. Shoemaker for me was my first sort of entree into goal-directed therapy and what it is. So let's talk about it. So I want to give some acknowledgments on my slides and data that come from Dr. Lundy Campbell at UCSF, and John Crite, who in his book was the section editor for oxygen delivery in septic shock. Early observations of survivors. So Shoemaker and others published multiple observational studies looking at shock survivors, septic shock survivors. And their findings were survivors achieve a higher value of cardiac index, oxygen delivery, O2 consumption, and lower oxygen extraction levels. Underlying assumption by them was that maximizing DO2 would increase O2 consumption and reduce tissue hypoxemia. Now, what's important to understand is, and you'll see it as we move forward, that they were looking at supranormal values and just doing everything they could to drive DO2 well beyond what would be considered normal. Ultimately, that's sort of been debunked as a thing that really does improve. But in Shoemaker's talks or publication, which I'll show you, he actually showed a lot of survival benefit by doing that. So does Shoemaker make sense? Well, it seems intuitive that improving tissue oxygenation would be beneficial. Okay. It's intuitive. What level of DO2, however, should be targeted, and perhaps timing of intervention is important. In other words, once you create such a deficit, can you really catch up? And it's kind of like ECMO, I think, in some ways. Patient selection certainly may be important. I think that applies to everything. So the things that I'm probably most interested in are the first two. Does affecting oxygen delivery matter? Well, many varied and conflicting studies regarding that over the years, up till current time. They cover a wide variety of ICU patients. They're instituted at various times. It sounds just like ECMO. Sounds like I'm talking about ECMO. And the data is a methodological quagmire. In other words, it's just very difficult to analyze all of this data. So in the Shoemaker's paper from 1988, there were essentially two different and very difficult studies tied into one. There were significant issues with methodology, critically ill, non-cardiac, high-risk surgical patients divided into two groups, control and protocol, each with their own hemodynamic goals. In the control group, they went for a DO2 of 2.8 to 3.5 as an index, which would equate to a 400 to 550 milliliters, and a consumption of 120 to 140, where the protocol index was driven up to 4.5 on the cardiac index, a DO2 of greater than 600, and that's indexed, and a consumption of greater than 120. All groups received fluids, inotropes, pressors, dilators, and so forth as needed. 252 patients ended up being randomized to control versus protocol, and when the study period was started, pre-op versus post-op. Analyzed the patient mortality by subgroup, early versus late, control versus protocol, cardiac index normal at baseline versus elevated at baseline. In all groups combined, the control, 57 out of 168, had 34% mortality, quite high. The protocol group had a 19% mortality. That is a statistically very significant decrease. Patients with normal pre-op hemodynamics had a mortality in the control group of 28%. So starting off with normal values decreased your mortality right off the start, and the protocol group went down to 10%. So once you flip over the edge to having abnormal or compromised hemodynamics would be perhaps a more appropriate way to say it, you were already behind the 8 ball. And catching back up again made a statistically significant difference as to your mortality, even if treated with this very significant change in protocol. Because remember, this is 1988. How they treated patients then, very different to how they treated patients now. So in a second series, 146 patients met the criteria for study. 58 were not randomized because 45 were not considered sick enough. The split remaining of 88 patients into 3 groups: a central venous catheter control group with normal hemodynamic targets, a pulmonary artery catheter control group with normal hemodynamic targets, and a PAC protocol group with supraphysiologic targets. Analysis for mortality: the central venous catheter group, 7 out of 30 died, 23%. If you use the PA to control the hemodynamics, PA catheter, then 10 out of 30, you had 33% death. But look at the protocol group with the supraphysiologic cardiac output and especially DO2 more specifically, 4%. That's huge.
Yeah.
When I remember reading this paper back then, back in the 90s, it made an impression on me. I was definitely affected by this, and thought to myself, the problem that we have is and this is translating into cardiac surgery and our patients who are on ECMO. VV ECMO is probably one of the most complex things that we do. It seems simple enough, right? Oxygenate the blood. But a lot of our VV ECMO patients are septic.
Yeah.
Mm-hmm. When we're VV, we are not providing circulatory support. And I think when you see the rest of this, you'll sort of kind of see where my mind went back then, that I've always felt that we're missing something. What that something is, I'm not 100% certain, but we're missing something. So let's go through some introductory stuff that's going to be important to understand. And this is going to segue kind of into John's talk. But so what's the background on O2 delivery? Why do we measure it? Does affecting it matter? How to make sense of this, and what my recommendations are. So the background on oxygen delivery includes terms, formulas, how do we measure it, how to measure oxygen consumption, how to measure cardiac output and cardiac index. So oxygen delivery, TO2, DO2, amount of oxygen delivered to the body tissue in 1 minute, and there's your formula. Oxygen consumption, or VO2, is the rate of oxygen removed from blood for use by the tissues. VO2 is measured with calorimetry. Now, we have to do that indirectly. What is the result of energy usage in metabolism of oxygen, or let's say aerobic metabolism? What happens from the energy usage or the metabolism? What happens? You expel something.
Produce carbon dioxide.
Produce carbon dioxide, exactly. Oxygen extraction, as reflected by EO2, is the slope of the oxygen delivery, oxygen consumption relationship, often expressed as O2 extraction ratio. And there's your formula there with your normal values. Normal value for DO2 is about 500 as an index meters per meter squared, or about 1,000 for the average person. And say oxygen delivery is not measured directly. DO2 equals cardiac output. times the arterial oxygen saturation content, the content of the arterial blood. And that is measured by the formula hemoglobin times 1.36 times the saturation plus 0.0031 times the PaO2. We all know that. Normal values, 1,000 mLs per minute or 500 milliliters per meter squared. Oxygen consumption could be measured by reverse Fick, but more practically, it's done indirectly by calorimetry. Normal values at rest, approximately 3 milliliters per kilogram per minute or 250 mLs per minute. And that's going to be reflected by your venous oxygen saturation and your venous CO2, PCO2. So this slide is a little interesting. I'm going to use my little mouse here. So in this box that you see here, you basically have what will be enough oxygen to have aerobic metabolism and not develop any lactate. So critical, oops, what happened? What'd I do? There, sorry. So critical DO2, which is here where C is the point below which oxygen consumption is limited by delivered oxygen content or amount. The slope of the line, which is this line right here, is going to be the oxygen is essentially going to angle based on the oxygen extraction rate. So if you look at the oxygen extraction, 80%, 60%, 50%, this line will angle based on what the O2 extraction is. All right? So what you're looking at here is as your oxygen delivery comes down and you reach this critical point, as you continue to go down, your oxygen consumption actually also goes down. You would, for obvious reasons because of the delivery, and you start to have increasing lactic acidosis. So this window here, this is the critical value. This is the point below which oxygen consumption is limited, now the consumption by the delivered amount, and it starts to fall with increasing lactic acidosis. And the angle of this is going to be dependent upon what your extraction is. 80%, 60%, 50%. Obviously, if your extraction, the lower your extraction, the better off you are. This is maybe a little easier way to understand that rather complicated graph. So if you look at oxygen consumption here on the left side, in the blue line, and look at it from right to left, you have oxygen consumption, and you have, in your red line, lactate. As your oxygen delivery goes down, which is down here on this line, goes down, you'll see that you reach a critical point. Now, any further decrease in oxygen delivery will result in a decrease in oxygen consumption and an increase in lactate level. So a little easier to see this graph versus the other. And here you can see that your oxygen extraction ratio continues to increase because those tissues want it until you reach this critical point, at which point this is going to have an effect on that, which is opposite of what you would want. So what is involved in O2 delivery? Well, there is a VO2 max. And VO2 max is basically the amount of oxygen consumed relative to exercise intensity. You can basically stress yourself as much as you want, but once you achieve your VO2 max, you cannot consume any more oxygen. Now that can be affected by a variety of things, including and probably predominantly training. However, if we look here, hey, I'm not accusing anyone of anything. I'm just saying he never even slows down on hills and it raises red flags. And we have a bicyclist and he has a bag of blood because he's blood doping himself. Yep. And this raises his hemoglobin. This is his blood he's giving back to himself. And of course, he gets his hemoglobin level, he gets his O2 content up, and his O2 delivery, and you can shift this VO2 max over almost instantaneously. So how do we control the DO2-VO2 ratio? Well, we can increase O2 content, increase the hemoglobin, and increase the FiO2. How do we can increase cardiac index. We can decrease regional oxygen consumption, hypothermia or controlling hyperthermia, and the control work of breathing, paralyze the patient, add sedation, all of that stuff. If they're flailing around on the bed, they're consuming a lot of oxygen. And we've seen a lot of patients on ECMO who all it takes is one little bit of moving, shaking, shivering, whatever it is, and their SATs plummet.
Yes.
So they're just living on that edge all the time. So how do we measure cardiac index or cardiac output cardiac index? Well, we have non-invasive techniques, which is the thoracic electrical bioimpedance method. And I've studied this before. I'm not that convinced. They say it's really quite accurate, but I kind of discounted it some years ago. There's the minimally invasive, which I'm a huge believer in. The lithium dilution cardiac output curve, also known as the LIDCO, which I've used it multiple times and absolutely love the device. It uses pulse contour analysis in order to determine a whole variety of things. It can measure intrathoracic volume by looking at systolic pressure variation, pulse pressure variation, the slope of the curve, everything. And it gives you you essentially take that pulse contour and you've calibrated it with the lithium dilution so you know what that pulse contour and cardiac output actually mean. So it's not quite like you're just putting it on there and using the pulse contour analysis. But when you look at the flow track, which is a very popular system by Edwards, and of course Edwards is a huge company, LIDCO, very small company, and they don't calibrate it at all. And I've always had uneasiness with that. However, their studies show that it's pretty accurate. But I'm one of those people, trust but verify. I want to do a lithium dilution curve or some type of validation that the cardiac output really is what it is. Now, TEE, the best way to do it. That's 100%.
Yeah.
And when you take LIDCO with their calibration and TEE, it is like on the money. Very accurate device. Invasively, there you can do echo or TEE, transpulmonary cardiac output, of course, with a PA catheter, and SCVO2 monitoring. Now, SVO2 monitoring is a little different than SVO2 monitoring. So when you look at the central venous saturation, and you just draw a line, from your PA catheter or whatever, and you have you're measuring it from the right atrium. It's very different than if you measure it from the superior vena cava. And the SCVO2 is actually the superior vena cava saturation. Normally, the SVO2 coming from the top part of the body is lower than it is from the lower part of the body. However, when you're septic and you're in septic shock, it's frequently the other way around. And it's actually a diagnostic tool to look at your SVO2, SCVO2.
SC.
So why measure? Why do we do this? Shock states, shock physiology, cycle of dysoxia, early observations of shock and critical illness and survivors, going back to Shoemaker again, and Rivers from Detroit, actually. Rivers is from Detroit. He's an ER physician from Detroit. And he actually, he patented this SCVO2 catheter that measures the saturation in the superior vena cava. What is it that we care about in shock? Well, blood pressure and oxygen delivery. That's very obvious. Shock physiology. Lack of adequate perfusion leads to a cycle of cell dysfunction, which leads to decreasability of cells consume the oxygen leads to cell death and eventually death of the organism. And here's a cycle, kind of a drawing. You have decreased cardiac index here, leading to decrease in DO2, leading to cell dysfunction, leading to O2 consumption decrease, leading to a further decrease in cardiac output and index, and it just goes round and round and round until it circles the drain and goes, finally disappears into the abyss. So DO2, here's an interesting graph I thought was worth looking at, kind of a takeaway message. DO2 is affected by arterial oxygen content and cardiac output. Arterial oxygen content is affected by the capacity, which is the hemoglobin, the saturation, and the partial pressure, the PaO2. And cardiac output is affected by heart rate and stroke volume. And so there's your formula for getting DO2 and your cardiac arterial oxygen content. This graph here I put on to show how in the preload, your left ventricular end diastolic volume, this is the Starling curve, we're all very familiar with it. You see the Starling curve here, you reach the top of the curve, and it doesn't matter how much more volume you give, it's not going to go up. In fact, it's going to go down, we know that. But adding inotropes to the situation, like dobutamine, increases this stroke volume, and so you push your Starling curve a little further north and can gain cardiac output by using inotropes. So appropriate use of inotropes is very important when we deal with patients who are in shock, whether it be septic or just shock in general, I believe. So let's look at this case. A 70-year-old man with a history of congestive heart failure was brought to our hospital because of altered mental status. On arrival in the emergency department, he had a temperature of 35.5 centigrade, so he was hypothermic, a heart rate of 125, respiratory rate of 32, and blood pressure of 74/38 with a mean of 50, and examination revealed a necrotic draining right foot ulcer. So I would say he's septic. The arterial blood gas measurement showed a pH of 7.16, PCO2 of 38, PaO2 of 80. He had a white cell count of 223. He had, no, that can't be 223. I think I made a mistake there. His hemoglobin was 7. He had a bicarb level of 14, and anion gap of 24, and a lactate level of 11. That's huge. That's high. That's scary high. The patient was diagnosed with septic shock and was started on broad spectrum antibiotics, aggressive fluid resuscitation, which usually leads to fluid overload. We all know that. And vasopressor agents. He was intubated and sedated for respiratory distress, and a central line was placed, and central venous pressure was initially 1. So he needed fluid, there's no question about it. But he was probably also vasoplegic. He probably was just massively dilated. 3 hours later, after 4 liters of crystalloid, the heart rate had decreased to 105. So there was some progress, and blood pressure had increased to 95 with a mean of 65. The saturation of venous blood from the superior vena cava, there's that SCVO2 again, was 52%, and repeat lactate was 9. So that's still really low. That's low. I know that I said that sometimes can be reversed, and that's a diagnostic tool, but 52 is really low. That's not one of those things. So what are the problems? There's a persistent elevated lactate indicating suboptimal oxygen delivery and tissue hypoxemia. There's a low superior vena cava saturation despite attempts to increase preload, stroke volume, and thereby cardiac output. This patient's lactate has remained high. So the clinical solution in this case, increase DO2 by increasing content. They took the hemoglobin from 7 to 10, an immediate improvement. They added dobutamine and titrated it to give them a cardiac index of 2.2 liters per meter squared. They increased the SCVO2 to 71%, and they got the lactate to finally normalize. and the patient was weaned from pressors and extubated in 2 days. Now, let's just hypothetically say that we took this patient, put this patient on VV ECMO. Let's say that they intubated them, they still couldn't oxygenate him, they still weren't happy, and they put him on VV ECMO. But we didn't treat, we made him a little better because we got some oxygen in him,
Right.
but we never really treated the underlying problem of the delivery. Now, we've increased the content. We did that, okay, because we added VV ECMO, but the circulatory dysfunction is still there. And I really wonder whether VV ECMO in this scenario would have been enough, and I'm going to rely on John for this one, or adding VVA to this patient for a period of time would have made sense. John, what do you think?
We see that all the time. We do a VV ECMO, and all of a sudden we'll add an arterial.
So,
Y off of that.
so I'm not crazy.
And what would have been this patient's cardiac output before they treated it?
Well, it was lower than 2.2 since that was their goal.
So
let's go back and see if they told us what it was.
So
well, I mean, based on those labs, I would say it was pretty poor in their blood pressure. I don't think I have that.
Well, what I was going to say was, you said earlier they treated with 4 liters of crystalloid.
fluid.
So what does that do to your hemoglobin?
Drops it.
Drops it.
Like
So
a
now
rock.
your oxygen delivery just took a major hit.
Yes.
You were able to volume manage the patient and saw some improvement, but your oxygen delivery dropped. So probably should have been giving blood either along with the crystalloid or in place of
Yes.
the crystalloid, and you would have had a hemoglobin of 10 much sooner than what they probably ended up with. But as far as answering your question, when you're on VV ECMO, if you're not near flowing and oxygenating near the cardiac index, in other words, if the cardiac index is 8 and you're only flowing 3, and through a VV ECMO,
Right.
you're not oxygenating but 30-40% of what's coming
At
through.
best, because
And
you
we
still
see
have
that all the time
recirculation.
too. And in sepsis, for example, you might see somebody with a very high cardiac output, right?
Yeah.
And you can't keep up with your VV ECMO. So we then take either additional venous drainage cannulas that try to flow more, or Y into and get an arterial cannula, so we're directly oxygenating arterial site.
I'm looking
so we
forward
see
to your
that.
talk
We see
tomorrow
that all the
because I
time.
came to your hospital and I saw something that I thought was crazy, and you showed it to me. I was like, "Come on, are you serious? I've never seen anything like it in my life." Okay, so I showed you this graph earlier, explained it, but take this when you want to sort of take a snapshot of it, on your computers or whatever, and apply it to this, and you see easily how this, what you see here, dealing with O2 delivery and not being below this critical DO2 point where everything seems to go the wrong direction. Lactate up, consumption down. You want to be more over here. I think this is your safety zone over here. I don't necessarily think there's evidence that continues to support supranormal values like way out here, but I think somewhere in this range is your safety window in terms of O2 delivery. And it bothers me that we really don't measure it. We really don't. We don't measure it. It's a simple formula. It's simple to figure it out. But when you're on pump and you're busy, or you've got so many other things, distractions going on, like you have to do QCs on the blood gas analyzer, okay, which is why you should use the Siemens Rapid Point 500. Plug for you there. Because it does the QCs automatically, and it's always available. And I actually think that has a DO2, it might have it, I'm not sure.
Well, I'm going to mention an easy way to monitor your DO2 on pump during my talk. A real easy way to do it.
Good.
Without having a fancy monitor and doing a whole bunch of different things. So.
You want to do it now, or you want to do it during your talk?
No, we'll do it during my talk.
Tomorrow or today?
No, today, the next one.
Oh, good.
Yeah.
Okay, so correlating this to perfusion, which is going to be John's job. That's the next talk. Do we flow enough during CPB? Well, the question really should be, do we optimize? Because do we flow enough? Well, you have to get the operation done. They can't see. They need the flow down. Right. No, we're not flowing enough. But are we optimizing? Are we flowing as much as we can, doing the best job we can to get enough flow to maybe not be at that tipping point, so they can do the operation, or are we just not flowing enough? I think you really have to look at this more critically. You have to be more realistic about what we do. You can't just say, I have to flow 5.5 liters or 6 liters on this patient, and the surgeon's, the heart's blowing up and I can't operate, for Christmas sakes, help me here. We have to figure out how to do this. But then if you're one of those people that thinks, oh my God, I can never give a blood transfusion, it's the worst thing I could do, I'm gonna go to hell and I'm gonna burn in the abyss for the rest of my life if I give blood, but the hemoglobin is 6. And you're having to optimize flow to help facilitate the operation, and you're not at 24 or 26 degrees, you're rather at 32 or 34 or 30 or normothermic. We got to think about this. I don't know that we really think this through real well. There's just, everybody's sort of all over the map. But anyway, and they have good outcomes. Would it matter on a big swath of patients? Probably not. Would it matter on a few? Probably so. But we just don't think that way. But that's important. I think that's something we're missing. But okay, I'm getting on my high horse here. How we manage our ECMO patients. Many VV patients are in septic shock, in fact. Temperature management, I think very important. Types of monitoring, DO2 and VO2. And do we optimize? Thank you. Excellent. Okay, so thank you so much. The audience is applauding. A huge audience. You know, if you want tickets to come to the MediWeb studio, all you got to do is tell me you want to give a talk, and you get free tickets for you and your family.
That's awesome.
Now, I don't pay transportation or anything. You got to get yourself here,
yeah.
But you can come here.
Yeah.
And just to come on this in here would be something. Now, do you want to do yours from there? Can you see that screen, or do you want to do it from here where I sit? Because I have this monitor.
I think I'll be able to see fine.
You'll be okay?
Yeah.
Okay.
So we have the clicker.
Oh, here's the clicker.
Just go forward from here.
Is that?
What do I need this for?
I don't know if you want to move your mouse around.
Oh, okay. No.
If you don't, then don't worry about it. Here, I'll take it.
Okay, I don't think I need that. Well, that was excellent, Joe, because the prelude to what I'm going to talk about, it couldn't have been more ideal, the way you worked into it from how goal-directed therapy started, and it really did start with sepsis. And in fact, I read an article as a sideline to researching this, that before Dr. Rivers and Shoemaker did the groundbreaking work that they did, the mortality was somewhere in the high 40s, dropped all the way down to the low 20s for sepsis because of the treatment that they did. It's probably a lot better.
They have a surviving sepsis campaign.
Right.
It's huge. And actually, I think it was higher. It was closer to 60%.
Yeah, oh, was it?
Mortality for sepsis. If you came to if you were admitted to the ER with a diagnosis of sepsis, 60% mortality. That was your number.
What do you think it is now, in the 20s or less?
Yes, I do.
Yeah,
I think it's
that's the impact that those gentlemen had, actually. And part of what I'm going to talk about here is there's a group of about 4 or 5 researchers that really started looking into goal-directed perfusion, probably in the early 2000s. And I'm going to really give a little tribute to them, because the impact that they've had on improving perfusion, and it hasn't fully taken hold yet, because part of what you just said about the difficulty in us monitoring delivery of oxygen on top of everything else we're doing is kind of holding people back. So hopefully we can make a little progress on that. But the day will come when we monitor delivery of oxygen as a global field, and we're going to see, I think, a big impact. So I don't have any disclosures on this lecture, but what was the premise of goal-directed perfusion? Well, originally, and still sort of is high oxygen delivery during bypass is associated with better renal outcomes, less ischemic-related complications, and shorter ICU and hospital stays. But what is the best means of achieving it, and how is it determined? Well, what is traditional perfusion? Traditional perfusion techniques gauge adequate perfusion according to body surface area and cardiac bypass temperature. This is something we all do every day, right? And has been shown to achieve high DO2 delivery of oxygen in about half of the cases. So I took a little ad hoc survey, Joe, when you called me a few months ago and said, would I do a talk on goal-directed perfusion? And I went around, we have a lot of perfusionists that I know and I can talk to, and I asked them, what do you think goal-directed perfusion is? And I got a whole variety of answers, and I don't think I got any of them that were actually correct. I take it back. One gentleman, perfusionist that has many years experience, did know exactly what it was. But I was shocked that I wasn't the only one who didn't know exactly how to define it. So some people said, oh, it's AMSEC standards and guidelines. Well, the American Society of AMSEC has created standards and guidelines based on clinical evidence, and currently accepted perfusion practices. And this document is intended to serve as a useful guide for teams developing institution-specific protocols to improve the reliability, safety, and effectiveness of their extracorporeal support services. AMSEC recommends that clinical teams use this document basically as a guide for developing their own protocols and for patients receiving extracorporeal support. So the answer is no. Goal-directed perfusion is not the AMSEC standards and guidelines. Some people said, well, it's evidence-based medicine. It's the same thing. Well, I'm going to come back to this in a minute instead of answering that. Well, what's the generic definition of goal-directed perfusion? And these are my words actually here. It's not something that I read, because if you Google generic definition of goal-directed perfusion, I don't think anything comes up. But it's providing the optimal clinical techniques, methods, and pharmaceutical treatments available to ensure adequate delivery of oxygen, but not only that, nutrients and fluid balance to the tissues in a clinical setting whereby the patient is no longer physiologically capable of doing so on his own. Well, what is a more specific definition? Goal-directed perfusion during bypass focuses on perfusion techniques that have been verified to achieve a high delivery of oxygen to the tissues with a consequential reduction in various ischemic-related complications, with a particular focus on reducing acute kidney injury. So how does goal-directed perfusion research studies differ from traditional research? And this is where it starts to become interesting. Traditional research perfusion studies observe a particular clinical or laboratory setting. They collect data, and in order to learn or draw conclusions from that information. Well, goal-directed perfusion studies, on the other hand, perform a specific perfusion strategy in order to achieve a specific target goal, and then assess the degree to which they've attained these target goals. We're going to talk about this. So is it evidence-based medicine? Well, an evidence-based practice is any practice that relies on scientific evidence for guidance in decision-making. Practices that are not evidence-based may rely on tradition, intuition, and other unapproved methods. So therefore, goal-directed perfusion and evidence-based medicine practices most certainly overlap one another and are in many ways closely connected. So what are some of the goal-directed perfusion parameters that one can look at if you're going to do a goal-directed study? Hematocrit and hemoglobin, fluid balance and nutrition, electrolyte balance, blood pressure, vascular resistance, both SVR and PVR, blood osmolarity and protein content, oxygen content of the blood, blood flow or cardiac output, arterial venous oxygen sats and the PO2s of each, lactate levels, and most importantly, delivery of oxygen and carbon dioxide production. Well, what is delivery of oxygen? Joe touched on this a little bit. Oxygen delivery is defined as the amount of oxygen delivered to the tissues or capillaries per minute. But how is it determined? Well, it has to be calculated, which Joe also talked about. Delivery of oxygen is the blood flow times the oxygen carrying content of the blood. And of course that breaks down to blood flow times the oxyhemoglobin portion, which makes up 97% of the amount, and the dissolved oxygen in the plasma, which makes up about 3% of the amount. And that formula is same thing that Joe was talking about, blood flow times 1.36 times the hemoglobin times the saturation of oxygen, 0.0031 times partial pressure of oxygen, your PO2. So when you look at this, what are the focus points that the parameters that we should focus on as perfusionists? Well, in purple there you see blood flow is something we can control. Hemoglobin is something we monitor. We certainly look at and control our arterial saturation, and we certainly control our PaO2. So those are the four variables. But you can actually simplify this, because any of us, even doing modestly diligent perfusion, shouldn't have to worry too much about our PaO2s being low. We should all be somewhere in the triple digits or higher. 150 probably be the lowest that most people would run, and way higher. And that's going to give you a 99% or really 100% arterial saturation. So to me, those are kind of already a given. And that simplifies it, because now, as perfusionists, we can just focus on what is our blood flow and what is our hemoglobin level. And this is what's going to give us an adequate delivery of oxygen. Okay? So we need to look at delivery of oxygen index, which is we're delivering a certain amount of oxygen per body surface area, right? And of course, that's the same formula divided by BSA. So how much delivery of oxygen index do we provide on bypass? Well, the normal adult rest range is somewhere between 450 and 800. I think, Joe, in your talk, you said something like 500 to 1,000. Milliliters of oxygen per minute per meter squared. And this can vary because it depends on what the person's hemoglobin is. If you plug in somewhere between 14 and 18 as a hemoglobin, if you're a cardiac index 2.8 to 4.0, maybe even 4.2 on some people, most people's arterial saturation is about 90, 92% with a PO2 of 90. So if you use those various, you're going to get a range of somewhere between 450 to 800 for your average person. But on bypass, it's much lower. It's somewhere between 180 and 380. And that's because our hemoglobins are going to be somewhere between 7 and 9. Most of us have cardiac index pump flows calculated between 1.8 and 2.4. Your saturations are 99% or better, and PO2s probably 150 or greater. So basically what this means is on bypass, we typically provide only about 35% of the at-rest DO2 that most people receive. And this, of course, is largely due to a lower hemoglobin and lower blood flow index, which I mentioned. So why do we care about delivery of oxygen on bypass? Well, the focus and the real focal point that it all started with is because of the delicate state of renal perfusion, the low PO2 levels in the medulla, and the high incidence of acute kidney injury post-bypass. This was really the impetus for focusing on how we can improve. So this was a slide that from a talk I gave about 2 months ago here, Joe, when we talked about the renal perfusion. I just wanted to go over why the kidney is such a big focus when it comes to delivery of oxygen. And there's very small print, I don't expect you to read that, but there's 4 articles there at the bottom, and I'm taking quotes from each one, so I just wanted to display them. Somebody can look them up if they want. And these are quotes from 4 research articles to do with tissue oxygenation. Kidney physiology and function are particularly dependent on O2 supply. This effect is particularly pronounced in the renal medulla, where PO2 levels run as low as 10 to 25.
That's just amazing.
It is not surprising that the kidney might be one of the first organs to be affected by a global reduction in delivery of oxygen. And in the 4th article, they quote, in vitro studies have demonstrated that areas of the kidney are prone to ischemic injury in cases of even slight reductions in renal delivery of oxygen. So, again, this is another slide that I stole from my own lecture back about 2 months ago with this, but just to remind here, the regional variation in tissue oxygenation of the kidney. The high renal blood flow is first directed to the cortex to optimize filtration and reabsorption, basically going through the nephron there, where the PO2 comes in at about 50. When it leaves the nephron, the blood flow then is going to perfuse exits the afferent artery, and then it's going to go to renal, leading to the renal tissues are perfused and leads to poor oxygenation, which is borderline renal tissue hypoxia. This effect is most pronounced in the medulla, where PO2 levels are 10 to 25. So this is one reason why, the main reason why, acute kidney injury and delivery of oxygen were so intimately connected, and the focal point was so strong when it came to delivery of oxygen. So, yeah.
I just want to add to this, because you taught me this also, is go back to that previous slide. This is what surprised me the most. I'd like you to just quickly elaborate on it. Hypothermia does not help you in this circumstance.
Hypothermia and hyperthermia does not change the metabolic perfusion needs of the kidney. And the reason is because all of the blood flow that goes to the kidney goes through the nephron. The nephron must do the work of absorption, filtration, and reabsorption, which costs a lot of ATP. In other words, you cannot go around the nephron and just perfuse the parenchyma tissues. You have to go through the nephron first. This requires an enormous amount of energy, and then it goes on to perfuse the renal tissues. So there's no such thing as a luxury perfusion to the kidneys or over-perfusing the kidneys. It's just like a packaging plant, like a package sorting plant. When it comes down the conveyor belt, the more boxes that come down, the faster the sorters have to work. That's the same thing that happens with the kidney. The more blood supply that you send down, the more the nephrons have to generate ATP to do the filtration and reabsorption work of the nephron. So you can't get away from this where we can just over-perfuse the kidney. They're on a borderline of adequate perfusion, and when you can only go less than that, you can't go above that.
And again, cooling them down doesn't
change anything.
Do you any good,
Nope.
because we have all believed that was protective.
I think it's PerfWeb 23 when I talk about delivery of oxygen. I think it's called. This is the slides from that, and I show proof that hypothermia does not preserve reduced metabolism of the kidney, and hyperthermia in exercise doesn't either. Your kidney's perfusion stays very, very controlled.
Constant.
Just about,
Almost.
yep.
Thank you. Sorry to interrupt you.
So how much delivery of oxygen is adequate for bypass? Now I want to, like I said earlier, I want to give a tribute, just like you did to Shoemaker and Dr. Rivers, Joe, in your talk, to really these early and current pioneers of delivery of oxygen on bypass. Marco Ranuzzi in Italy, Philip de Sommer, and J. Trent Magruder here in the States have done an awful lot of work on this. And these aren't the only ones, by the way. A lot of these guys have collaborated together, but between these three, they've probably done over 25, 30 papers just on goal-directed perfusion with delivery of oxygen, and we're going to talk about carbon dioxide consumption. So I just wanted to give a tribute to them, and a lot of the papers I'm getting ready to go over are by these gentlemen. So what has the goal-directed perfusion research taught us in regarding delivery of oxygen on bypass? So I'm going to go through some of these articles now. So here's a Ranuzzi paper back in 2018, pretty recent. They looked at 9 institutions, 326 bypass patients, and the purpose was to determine whether a goal-directed perfusion strategy aimed at maintaining oxygen delivery at 280 or greater reduces the incidence of acute kidney injury. Now, part of what you're going to see is a lot of these studies take a different approach. Some do a more higher delivery of oxygen, some do lower. They're really still trying to focus and find where is that key point that we need to be above. So they had a goal-directed group where the perfusion was greater than 280 and a perfusion strategy group where they just based perfusion like most of us do on body surface area and patient temperature. The goal-directed perfusion group had an AKI reduction of 67% compared to the perfusion strategy group. Magruder and his group did a study, nadir oxygen delivery on bypass in regards to hypotension, and this is back in 2015. They took 170 patients, matched with a 1-to-1 propensity matching score, and they wanted to determine what is the absolute lowest delivery of oxygen on bypass that then becomes a risk factor for AKI. They retrospectively analyzed 85 patients who developed AKI with another 85 control patients who did not. And remember, these patients were matched for the propensity score of 1-to-1. So there are a lot of similarities, no outliers and differences, and they found in these matched patients, 85 who developed AKI and another 85 who did not. They wanted to see what the difference was. And what was the result? Well, in the non-AKI group, 85 patients, they discovered that they received a delivery of oxygen greater than 230 milliliters a minute per meter squared. And the AKI group averaged a delivery of oxygen of only 208. The non-AKI group had a mortality rate of 5.9, and the 30-day mortality rate on the AKI group was 35.3%. They found that there exists a threshold, which they believe they saw in this study at about 230, for the development of AKI in cardiac surgery. De Sommer, one of the guys I mentioned earlier, a study back in 2011, O2 delivery and CO2 production, some of the things you talked about, Joe, in regards to acute kidney injury. They looked at 359 cardiac surgery patients, and their purpose was to explore the association between delivery of oxygen on bypass and carbon dioxide production and how that relates to postoperative AKI. A retrospective analysis, multi-center study, 359 patients were analyzed for creatinine levels and AKI postoperatively. What did they find? They identified a group with a nadir DO2 of less than 262, okay? What they found was above this threshold, there was only a 7.4 incidence of AKI stage 2. And below this threshold, there was a 23.2% incidence of AKI. And this is a predictive value of 92.5%. Ranuzzi, oxygen delivery during bypass and relating to acute renal failure back in 2005. And again, this is why these guys have pioneered this. They've been doing this back from about 2000, now almost 20 years. Took 1,048 consecutive cardiac surgery patients, and their purpose was working under the premise that poor oxygenation of the renal medulla, which I was mentioning earlier, during bypass may cause renal injury. They proposed that the detrimental effects may be reduced by increasing oxygen delivery. Okay. Well, they indexed the lowest DO2 on bypass and an incidence of renal failure. They identified a threshold of 272 for acute renal failure. If you had a delivery of oxygen on bypass greater than 272, you only had a 9% incidence of acute renal failure and a 1.7% mortality rate. If you were below that, you had an acute renal failure incidence 2 to 6-fold with an 11% mortality rate. Magruder, in a pilot goal-directed study initiative, again looking at acute kidney injury after cardiac surgery, took 172 patients with a 1.1 propensity matching score. Their purpose, do a goal-directed study to determine if a DO2 of 300 would decrease the incidence of postoperative creatinine levels and AKI. They took 88 control group patients and they perfused them with the delivery of oxygen of 240. And they took 88 and did delivery of oxygen of them of 300. The results, their control group had an average creatinine increase of 22% with a post-op AKI rate of 24%, and the goal-directed group increased creatinine was only average 9% with a post-op AKI of 9% only. So where did we find all this? Because if you look at the papers I just mentioned, some looked at a DO2 level as low as 230, and some looked as high as 302. So what is the accepted threshold? What should we be doing on bypass after almost 20 years of research? And most people accept that these two research papers that were done by Ranuzzi and DeSommer, and they've done more than one, that the threshold is somewhere between 262 and 272. And if you really want to be safe and err on the side of caution, use a 272 delivery oxygen index when you're doing on bypass, and we're going to look at that. Now I want to talk about the carbon dioxide production, which is something you talked about quite a bit, Joe, as well. In the human body, carbon dioxide is formed from the metabolism of carbohydrates, fats, and amino acids, and is the waste product of cellular respiration. The body gets rid of excess CO2 during exhalation, but at rest, with a total volume of 500 milliliters, humans exhale approximately 20 milliliters of carbon dioxide per breath, or approximately 240 milliliters per minute at 12 breaths per minute. The carbon dioxide production index is the carbon dioxide produced per minute divided by the body surface area, right? So if you have the 240, what I just said, and let's just say somebody has a BSA of 2.0, normal breathing is going to produce 100 to 120 milliliters per minute per meter squared of carbon dioxide, but on bypass, the normal range is somewhere between 32 and 50 carbon dioxide index. So what has the goal-directed perfusion research taught us regarding carbon dioxide production? We talked all about the oxygen delivery. What about carbon dioxide production? Now, there's known predictors of hyperlactemia. And basically, it's defined as lactates above 3 during bypass. And those known predictors are a carbon dioxide production, VCO2 index, of anything greater than 60. If you're producing more carbon dioxide greater than 60 milliliters per minute per meter squared, this is a direct predictor that you're producing lactate. Again, on bypass, we should only be producing somewhere between 32 and 50. So above 60 is an indication we're producing lactate. We're going to talk about why that is. The respiratory quotient is a production of carbon dioxide divided by the consumption of oxygen, RQ, the respiratory quotient. If it is ever greater than 0.9, okay, this is going to be an indication of that we're producing lactate. And we're going to talk about these a little further. So what is the respiratory quotient? I stole this slide off another lecture. And basically, I just want to show you that RQ, if you look in the yellow there, it's the volume of carbon dioxide produced divided by the volume of oxygen consumed. So if you want to look at where they come up with this number, the next yellow box there says simplified equation for aerobic respiration of glucose is 6 molecules produces 6 molecules. So if you look there, 6 carbon dioxide molecules are produced for every 6 oxygen molecules consumed. So therefore, this reaction equals 1. So at the bottom I write there, if any degree of anaerobic respiration occurs, RQ values rise significantly above 1.0. So if we get into anaerobic respiration, this respiratory quotient will go above 1.0. And we're going to talk about why that is in a minute. So those are 3 known predictors of lactate production, meaning we're into anaerobic respiration, anaerobic metabolism. If any of these things are occurring, okay? So if you look at the bottom, delivery of oxygen compared to carbon dioxide production ratio, This needs to be less than 5. And let's just show you why that is. Let's just say, for example, we're delivering 300 milliliters a minute delivery of oxygen, and we're producing 40. Remember, the normal range is 30 to 50. So if we're in a normal state, we're delivering plenty of oxygen, let's just say it's 300, divided by 40, that gives us a ratio of 7.5. So you can see that if your numerator, 300, your delivery of oxygen starts to drop, and you're only delivering, 250, and your carbon dioxide starts to rise, ups to 50, right, you're going to get into that 5. If you get below 5, you're having a lot of carbon dioxide production and very little oxygen delivery. So you want to always keep this above 5, and we're going to see about how all these work in a minute. So here these gentlemen again did research, and I'm going to talk about their papers where they focus on CO2 production and the effects that it has on acute kidney injury. So in this study, back in 2011, their purpose was to analyze any correlation between oxygen delivery and carbon dioxide production during bypass. Well, their method was a retrospective analysis, 359 patients at 2 institutions, and they monitored creatinine levels and AKI stage 1 and 2. So what were their results? They identified that there was a specific cutoff value for elevated creatinine and AKI, and the delivery of oxygen cutoff value was 262, we talked about earlier, but the delivery of oxygen versus carbon dioxide ratio had to be greater than 5.3. A minute ago I mentioned 5.0. Some studies have showed 5.0. In this particular study they found it needed to stay above 5.3. This had a predicted accuracy of 90%. So what's happening here, Joe, is that since if you read their articles, they tell you that ideally what they would like to have happening here is that we have a probe that we can slap onto our venous line and it gives us live lactate levels, continuous reading. We don't have such a device. We need to seek out, and they're seeking out in these studies, what is going to be an immediate predictive indicator that we are going into anaerobic metabolism. And that's what they're pinpointing here. And these are the known predictors of generating lactate, and they define hyperlactate is greater than 3, as I mentioned before. Okay, so CO2 production greater than 60, respiratory quotient greater than 0.9. I demonstrated on that slide that, it needs to be no greater than 1.0, but in their research they actually fine-tune it to where 0.9 is actually the cutoff, and delivery of oxygen to CO2 production of less than 5. So the purpose, because knowing that, this study aimed to identify predictors of hyperlactemia during bypass with a whole series of derived parameters of oxygen and carbon dioxide. So they're looking for more things. They're really digging into the weeds here to see what other parameters of oxygen and carbon dioxide are there out there that can tell us, maybe things can tell us even sooner or faster or more accurately that we're entering into anaerobic metabolism. And their methods, they took 54 patients, they sampled every so often lactate levels and various derived parameters of delivery of oxygen and consumption of carbon dioxide. And I'm going to get a little bit deeper into this study. So they basically entered the patient's age, gender, weight, body surface area, of course, and cardiac bypass time. And at the end of each sampling time, they recorded these variables: arterial PO2, arterial SAT, arterial PCO2, same thing with the venous PO2, venous SAT, venous CO2, hemoglobin level, lactate level, and sweep, your pump flow rate, and they were measuring the exhaled carbon dioxide from the oxygenator, the ECO2, using a capnograph. It gets a little complicated with a capnograph because you have to, there's many issues with it, so I'm not going to go into that exactly because not all of the, unfortunately, not all of the exhaust nowadays comes out of the exhaust port because a lot of oxygenators are vented. But anyway, if you do sample it and you're getting what you feel is accurate, you have to do a calculation to figure out what is actually the production of carbon dioxide index, and there's the formula. We can talk about it another time. So now these are, using this data, again, they were trying to find all kinds of other variables of oxygen and carbon dioxide that could be calculated. And they did a whole bunch of things. The AV oxygen content difference, oxygen consumption index, delivery of oxygen index, O2 extraction ratio is a little bit different, veno-arterial PCO2 differences, delivery of oxygen versus carbon dioxide consumption, and the respiratory quotient. So they did all of these calculations to try to find, was there anything more that they could use as an indicator that we were going into anaerobic metabolism. And here's a study specifically about that. by Ranuzzi, anaerobic metabolism during bypass, predictive values of carbon dioxide-derived parameters. So they found in this same study there was no correlation between PaO2, SVO2, and cross-clamp time and body surface area. There was no correlation. Whatever those numbers were, they were not indicating that we were into producing lactate. And that's surprising because a lot of people rely heavily on the SVO2. And it is actually not.
I have.
Yeah, and it's actually not an indication that you're into anaerobic metabolism. But all of us do that. But there was significant correlation was found between lactate production and cardiopulmonary bypass time, the consumption of carbon dioxide versus the delivery of oxygen, the carbon dioxide produced versus the oxygen delivered, the carbon dioxide produced versus oxygen consumed. And here's what they found. Now, there was 54 patients, so this slide, don't let it be confusing, because it's a little confusing, but basically they found that they sampled, out of the 54 patients they did, they had 130 samples where the lactate was under 3, and they had 37 where the lactate was over 3, and they wanted to see on these indicators what was the difference. Well, part of bypass time for those were under 49 minutes or less, did not produce lactate, and those at 69 or greater were. We don't know what the threshold is on bypass time. Carbon dioxide produced, 51.4, less than lactate of 3, and 82 above. Remember, our cutoff there is greater than 60. So if you had this CO2 produce index, VCO2 index of above 60, you were producing lactate. And you can see there they found that. Respiratory quotient, what I mentioned before, the cutoff was 0.9. If anybody who was in the range of 0.77 was not producing lactate. When you got above that average of 1.35 on the samples they took, they were producing lactates greater than 3. So these are very good indicators. So here's the delivery of oxygen versus the consumption of carbon dioxide. Remember the 5.0 to 5.3. Here again, if you were in the range of 6, you were producing, if you were above 5 in the range of 6, you were not producing lactate. If you were below 5, 4.14 there, you were producing lactate. So these are very good indicators. So now let's look here at the graph that they have. So if you look on the left, it's just acute kidney injury, rate of AKI. And on the bottom, it's delivery of oxygen. Remember, we've concluded that somewhere between 260 to 270 is where you need to be as your absolute cutoff for delivery of oxygen on bypass. And I've drawn a red line there. Now look to the left of the red line. Look at the rate of AKI when you are below a delivery of oxygen of about 270. It's way up in 20, 25, 30%. Look how it suddenly drops all the way down to 5% when you deliver oxygen to your patients at about 270. Look at that drop from 25 down to 5. And it stays that way, with some variance along the way. Look at the delivery of oxygen versus carbon dioxide consumption. Remember, this is the 5.0 to 5.3 cutoff. AKI incidence on the left, 25%, 35%. And look at the sudden drop when you get to keeping this ratio at around 5, all the way down to 10. And as you go along the right, it even drops down to as low as 5 in some studies. And so look at here, same thing with an additional thing. And I highlighted in yellow there, a little hard to read. But remember, so here's our nadir delivery of oxygen and AKI stage 2. Less than 262, remember our cutoff, 262 to 70? Look at the rate of AKI, 20, 24, as high as 30%. When you deliver a greater, which is in yellow there, greater than 262, drops all the way down somewhere around 6 to 7%. Our threshold of delivery of oxygen to the CO2 consumption, remember I said 5.0 to 5.3. If you're less than 5.3, where you shouldn't be, 20% and thereabout. If you're greater than 5.3, drops down to about 7%. And the final thing is, people always ask, well, is there a nadir hematocrit? Well, they actually looked at this as well, and if you want to keep a general rule in your mind as to where you should be on pump as a nadir hematocrit, it really matters more the delivery of oxygen. But your nadir hematocrit, if you look at it, AKI rate of about 18% if you're below 23.5% of hematocrit, and if you're above that, it drops down to about half of that. So these early pioneers, Ranuzzi, de Sommer, and Magruder, what did they demonstrate? Number one, they demonstrated to us that delivery of oxygen during bypass falls below a critical value, 262 to 72. Organ hypoxia is triggered. It's very clear. They've done over 20 studies, and Joe, every time they did a study, they found the same results. Remember, we talked about this in one of the other presentations, that something like 70–80% of all research can't be duplicated by somebody else. Well, theirs has always been duplicated. With consequent tissue acidosis leading to an increased production of carbon dioxide, and that this mechanism may be a determinant of impaired postoperative renal function. They demonstrated that in hypoxia or dysoxia, cellular metabolism becomes anaerobic, and the ensuing acidosis, the result of the production of hydrogen ions within the cells, produces carbon dioxide via the carbonic acid buffer system, right? So what's happening is, people say, well, if I'm not delivering oxygen and I'm not anaerobically metabolism, how am I producing carbon dioxide? When you go into anaerobic metabolism, you actually produce more carbon dioxide, and this is why. Because you're becoming acidotic. And all these, if you look on the left, all these hydrogen ions come into the carbonic acid buffer system formula, push it over to the right, and produce all this carbon dioxide. In fact, they produce an excess carbon dioxide. Okay?
Yeah, try to get the pH up.
This is
blow it off.
why that cutoff of greater than 60 of CO2, what I was saying, is an indication of anaerobic metabolism and lactate production, because your carbon dioxide is going to actually be higher when you're in anaerobic metabolism because of how powerful this system goes into motion. What's the third thing that we learned from these gentlemen? They demonstrated that when production of carbon dioxide rises above 60, what I just said.
Use consumption. You mean consumption?
Consumption, yeah. They always use V for consumption and production. So, in the setting of inadequate delivery of oxygen, that an escalating anaerobic metabolism is occurring and elevated lactate levels will very likely ensue. And number 4, they demonstrated that in hypoxia, cellular carbon dioxide production versus oxygen consumed, that's defined as the respiratory quotient, has a critical threshold level of 0.9, and any respiratory quotient greater than that is highly predictive of anaerobic metabolism, and elevated lactate levels will ensue. And number 5, they demonstrated that the delivery of oxygen to carbon dioxide production ratio, the DO2 versus VCO2, has a critical threshold level of less than 5.3, and any value less than that is indicative of an inadequate delivery of oxygen, results in increasing production of carbon dioxide through anaerobic metabolism. And if you want to see an example, let's say we're the happy face there, we're delivering more than enough oxygen, cutoff level is 270, but let's say we're delivering 320, and we're producing a normal level of carbon dioxide, 40, which is the normal range. Look at our ratio, it's 8, well above the 5.3. If we're only delivering 240 of oxygen and our carbon dioxide level production is 60, look, we're down to 4. So this is why this ratio makes a lot of sense. So now, Bob Groom did a wonderful research review paper on all of this and quoted all these gentlemen in that paper as well. And I'm going to go over, this is sort of the final little section of the talk, but I'm going to go over what he did and he talked about in 2017. Well, first thing he did was took a little non-scientific survey of perfusionists in 2017. And he asked them, do you measure venous oxygen saturation levels during bypass? 85% of perfusionists do measure venous oxygen saturation. He also asked, do you routinely measure carbon dioxide production index on bypass? Only 9% of perfusionists measure carbon dioxide production index. He asked, do you routinely measure venous PO2 levels during bypass? 71% of people do measure venous PO2 on bypass. A lot of people don't take a venous blood gas. The last question he asked was, do you routinely measure serum lactate levels during bypass? And 43% of people, perfusionists, do measure serum lactates. So at his institution in Maine, they created a care plan that estimates delivery of oxygen based on hematocrit. They enter patient parameters, the procedure, the age, the height, weight, and hematocrit. And then this generates a table that indicates the flow that's needed at various hematocrits to maintain your delivery of oxygen above that 273 critical level, okay? So here's the screen off of their computer in their hospital. So you don't have to focus on all that, that's all the parameters, but look what it generates highlighted in yellow there. Depending on your hematocrit, it tells you how much pump flow you need to have to keep the 272 delivery of oxygen. If you have a crit of 20, you need an index of 2.8 and flow 5.32 based on this patient's BSA and so on. And they calculate it from a crit of 20 over to 28. So if you're at 28% crit, you don't need to flow 5.3. You can flow down as low as 3.88, and you're still delivering that critical threshold of above 272 delivery of oxygen index. So here's a monitor. They have live readings of this, and it's a little hard to read, so I wrote on the right margin there what you're seeing. The top one reading there is 303.94. That's your delivery of oxygen index. Remember the cutoff, 272. So on this patient, they're delivering well above the threshold for necessary delivery of oxygen. The production of carbon dioxide, remember that should be between 30 and 50, is 45. And their ratio, delivery of oxygen versus consumption of CO2, which needs to be above 5, is reading 6.1. So this is a wonderful software program that I think they developed, where they do real-time monitoring of all three of these critical parameters to make sure that they are keeping the patient out of any semblance of anaerobic metabolism. And here's another screen that they generate, and I'll just show you the one in yellow there. And it does show you these same things, delivery of oxygen, if you look across the very top, SVO2, delivery of oxygen, the ratio. And if you look, it'll give you a maximum that they reached during the case, and below the yellow is a minimum, but the average shows you there, let's say DO2, they averaged 294 delivery of oxygen, keeping well above the 272. They, that ratio that's supposed to stay above 5, look, it's 11.85, okay? So this is a really wonderful thing. So basically, I want to thank you for listening, and I want to propose some discussion. And basically, what I want to say to you know, we talked about this earlier, is, okay, all this sounds fine and good, but what can I do with this tomorrow to be a better perfusionist? So since adequate PaO2 and arterial saturations should be a given. If your PaO2 is above 150, your arterial saturations are going to be essentially 100%. So those two items basically should be a given. So when you're looking at your formula for what you should be, easy way to deliver of oxygen index, okay, you can basically look at your calculation, and what you're going to want to know is, what do I need to flow if my hemoglobin is 6 or 7 or 8 or 9? So that's why I've highlighted the hemoglobin there in red. And so if you look at your delivery of oxygen formula there at the middle one, you know your delivery of oxygen number wants to be 270. So you're going to solve the formula for flow. You want to know what your flow is. So you're just going to solve the formula differently. You're going to plug in, see at the bottom there, I have the flow and the hemoglobin in red. If you have a hemoglobin, if you just do these three calculations, we want to know what you're supposed to flow on this patient. And on this particular patient, I assumed a BSA of 2.0, and you can use 1.0 for your saturation, 100%. You just put 1.0 into the calculation. And then your PaO2, you can use whatever you want. It's not going to change things very much because that's a very tiny factor, but just use something like PaO2 of 200. And then all you have to do is put in your hemoglobin numbers of 7, 8, and 9, and it'll tell you what you need to flow. For a hemoglobin of 7 on this patient with a BSA of 2.0, you need to flow 5.36 liters. You plug in a hemoglobin of 8, 4.7, and a hemoglobin of 9, 4.23. So what does this tell you? Well, first of all, if your hemoglobin is 6.7, you're probably going to tell the physician, I need to add blood, right? And you're going to get yourself back above 7. But you can see that if you're at 6.7 hemoglobin, you might have to increase your flow a little bit. And anywhere in this range, you're going to be fine. If you have a hemoglobin of 7.5, you can still flow the 5.36, and you're going to be overflowing your target of 272. So this is a real quick, easy way of basically just solving the formula, putting in your known delivery of oxygen of 272, you put in your body surface area and plug in 3 different hemoglobin levels, which you're going to run into on bypass, almost always 7 to 9. And it'll tell you what your flow rates need to be. So now you're not flowing according to BSA and body temperature anymore. You're flowing according to keeping your threshold of delivery of oxygen above that critical level that we know is so important. So here I show it to you to solve the formula for, put 272 in for the delivery of oxygen, whatever your BSA is, and you're basically just solving for the formula. I think these slides are extra. So thank you guys for listening.
Thank you.
Give myself a hand.
Can you do me a favor? Can you go? Can I see your
Yeah.
clicker? I want to go back to a slide, David. I want to. Oh, here. It's over here.
There's a lot of them.
Click. There it is.
Yeah.
Right here. That's the slide I want to ask you about. So if you increase your nadir DO2 it makes a difference. If you increase your nadir DO2 and your CO2 production, alone makes a difference. If you raise your nadir hematocrit on its own, it makes a difference. Did they look at all three combined, optimizing all three of those things? Since that slide tells me they looked at one thing, and one thing. What if they took those patients and they optimized analyzed all three of those simultaneously?
I think that's what they do. I don't think if you're just gonna look at delivery of oxygen and try to keep your delivery of oxygen above 270, let's say 272, you are, I would say with a very high likelihood, gonna be doing an excellent improvement for your patient. But it would be worth it to know, if what your production of carbon dioxide is as well, right? Because
so what I'm saying is, I might not be asking my question well. So let's just use the first two. So let's say the nadir DO2, the first one was greater than 262 mLs per minute per meter squared. The delivery. So your DO2 was greater than an index of 262, which is good.
right.
But your hematocrit was less than 23.
Well, see, that's why this slide is a little bit of an off the mark slide, because the whole point is, if your hematocrit drops, you increase your flow and you keep your delivery of oxygen up.
Right.
So the hematocrit alone is not an indication of anything, because you can flow more as your hematocrit is low, and then when you give blood or concentrate or whatever and bring your hematocrit back up, now you have the ability to flow less.
Right.
Which is why I just showed that three calculation at the end.
Yes.
So this is what I see all the time. I'm watching somebody do a case. The hemoglobin is in the 6s. Hey doctor, can I give 2 units? Hemoglobin 6.5. Yeah, drop in 2 units. They drop in 2 units. The hemoglobin goes up, but they never change the flow ever. So in other words, when you had the lower hemoglobin, and now you've dropped in blood and you didn't change your flow, when your hemoglobin was low, maybe you should have had a higher flow until you got your hemoglobin up. That's why targeting a delivery of oxygen keeps you above this level, even in the face of hemodilution, something happening where your hemoglobin is low, you have a small patient, you couldn't take off volume or something like that. So the hematocrit really becomes your indicator as to the fact that you need to flow more or less.
Yeah.
It's not in and of itself, which is why a lot of studies that just say, well, AKI, this is a famous thing. We had a hemoglobin below 21 and we had AKI, so we can never have hemoglobin above 21. Well, you could have if you had flown more to deliver the oxygen. It has nothing to do with it. With the I remember, all of you guys went to THI, I did too. We wouldn't give blood.
Not me.
Not you?
No.
Well, we'll go there one day. We didn't give blood if the hemoglobin was 5. It had to be.
It was crazy.
It had to be below 5.
And you didn't flow enough.
Probably didn't. But if you
Shumway, 30, 30, and 30.
And I'll tell you, if you wanna really open discussion to something, I presented almost 15 papers on adequate perfusion, and not one of them looked at blood pressure. Do you realize that? They didn't even look at it. It's not part of the delivery of oxygen formula. And people focus so much on giving vasoconstrictor on bypass, keeping your blood pressure up, and reducing acute kidney injury, which reducing acute kidney injury had to do with almost every single one of these studies. They don't even mention blood pressure, right?
Right.
But how many times have I said it? I've said it. I say it all the time. You say, thanks, bud. I say it all the time. Good pressure is not it's not exclusive to good perfusion.
Right.
You can have a great pressure and lousy perfusion, as is evidenced by, I won't say, this was many years ago. What do you do when you have given more neo than you intended, and the blood pressure is going to skyrocket because your SVR is going to skyrocket, because your blood vessels are all going to constrict. But you just have to fix it. There's no point in making everybody else in the room upset. What do?
The famous trick, lower the flow.
You lower the flow and
Go up on the
turn your
gas.
vaporizer up all the way. So you still have a blood pressure of 70, not 170, but you don't have good perfusion at all.
If you've ever mixed your Neo syringe double strength because you figured, instead of giving, half a cc, I can give a quarter of a cc, and you kind of overdid it and your blood pressure skyrocketed and you turned your flow down to almost nothing and you still had a pressure of 90 and you turned your vaporizer to 5 and you still sat there for a minute or two before it started to come down, you know exactly that your blood pressure is indicating. Now,
I had a friend, I'm asking for a friend.
Yeah, right.
I was asking for a friend.
Now, we say this every time when the blood pressure conversation comes up. You can't run a 0 or a 10 or some ridiculously low blood pressure. Why? You have to maintain capillary integrity. The blood pressure, as long as you're maintaining your capillaries open and you're not collapsing your capillaries, then blood flow is going to go. Do I know what that number is? Do any of us know what that number is? It's probably patient dependent. I don't know
There is
exactly.
I think there is a doctor. Remember Dr. Garami? He talked about that. Your capillary opening pressure, and it's somewhere in the 50 range, isn't it? I don't remember.
To maintain capillaries open,
and it may be the because when he was doing the TCD, he was talking about. Now maybe it does depend on the patient, but I don't think it's 50 seems a little bit high because
Probably,
people have perfused their brain with a 40 certainly before. But I don't know what that is. It might be 30. I don't know.
Yeah, it might. It probably.
Good question. I need
probably
Dr.
is.
Garami to come back.
I worked at a place not too long ago where they kept the pressure on bypass was 35 to 49, never above that.
Well, I told you about
And I never had any. I never had even a problem with AKI because I asked them. And
that's what they say.
That's what they said.
Come on. I mean, do you have any? I mean,
well, it was.
Everybody does the toughest cases, and their mortality is the lowest. Give me a break.
Well,
I don't buy
they've
that.
been doing it for. They've been doing that for about 25 years at this place.
But
and it's a busy place.
Oh yeah, but if you have a 7% renal failure rate and predictable 1.5 to 2.5%, 3% mortality for whatever, I mean that's acceptable. A stroke rate of 7.5%, that's acceptable. But is that really acceptable? That's the whole point. Is what do we find to be acceptable? Is 7% stroke rate, a 7% renal failure rate, 25% renal rate, 15% renal failure rate? Is that really acceptable?
It's only acceptable because everybody else is doing it.
Right.
That's what people measure it by.
Right.
Well,
and
everybody
that's
else,
a horrible.
I guess it must be okay. Right.
Yeah.
So we're not doing any. Right. Exactly.
Right.
So what do you think about? Would everybody like to take a 5-minute break, and then we'll come back and open the phone lines and continue the discussion for a little bit of time? Would that be okay? You want to take? How much time do we need to take a break?
10 minutes.
We need 10 minutes because we have to play our obligatory advertisements. Okay, yes, we need to satisfy our requirements for our generous advertisers. They're all great. So we'll go to break for 10 minutes, play our advertisements, and be right back. So give us 10 minutes.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive 2-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial, direct, and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Mics are live. Hey, Tabs.
Hey.
Hey. Okay, welcome back. We're gonna wrap up with our opening the phone lines and doing our panel discussion on the topics and conversations from today. Tammy, to lead us off.
Rodell.
Oh. that's excellent delegation. Excellent delegation. No, John has talked about DO2, and Joe picked up on the DO2 after all the conversations they've had during all these talks. It's interesting that, it's just coming to light now. I mean, I saw it a few years back, and, this goal-directed perfusion is a great thing. I think, and don't quote me on this, LivaNova is doing something with their electronic medical records. With Connect, and it has to do with DO2. So it's making its way into the. That's
actually what I was going to bring up.
Into that world as well. So it's one of their nice little markers and a selling point for EMR.
Oh, sorry.
It's interesting. It's very interesting.
Right. As we're moving into where we're going to have electronic charting, I mean, that's going to happen.
Mm-hmm.
That is something that I've seen in the presentations from Soren,
LivaNova,
LivaNova, whatever.
Yes.
Sorry, can't keep up.
Yes.
Their Connect system, as well as some of the other ones out there. And they're trying to make that, there's all kinds of parameters. But that's one in particular they are all focusing on.
Yeah, it is based on, I believe, that Ranucci study. And it actually will show up on your screen on your EMR. It will flash something on your screen and say, like, hey, you're below your threshold, which was kind of interesting. It's again, nothing that I had, when I was starting out, but it's a great paper. These are great papers. And AKI, it's a big deal.
It is a big deal, and I think that I said this earlier when before we left. I think what we accept is unacceptable. What I think.
Yeah.
I think, we're all so paranoid about blood transfusions. We are. And I think rightfully so. It's a liquid tissue transplantation.
Right.
Right? We all agree with that. And there are consequences
Absolutely.
to giving transfusions. But there's real consequences to anemia. Real consequences to having, I think, a hemoglobin on pump of 6. I've heard of it many times.
Right.
I talked about Shumway. Do you all know what we all know who Shumway was, right? We all know who he was, right? From Stanford.
Oh.
Shumway. Back in the old days. He's one of the Cooley, DeBakey, the godfathers of cardiac surgery. And 30-30-30 is a flow of 30 cc's per kilo, a pressure of 30, and a temperature of 30. So that's 30-30-30. That's how he did all of his cases. And people survived. Now,
Now all the data, there's more data.
People survive.
Right, people survive.
So people can survive a lot.
Well, it doesn't mean they're not getting an insult.
Well, it also doesn't mean that those patients that didn't make it, that they wrote off for some other reason, would not have possibly made it. Maybe some of them, maybe none of them. I really don't know. Intuitively, however, I think that if you can reduce AKI rates by 1%, by changing something that we do every day when we work, I think that has impact to that 1%.
Absolutely.
Well, sure.
Do you agree?
Absolutely.
Yeah.
Well,
But we don't.
I think your point of what's we find or other people find or institutions find acceptable is unacceptable. What is the acceptable rate that of people suffering an insult or dying that is acceptable if we can change something about it? That should be 0.
That's exactly my, yes.
Right?
That is what I have been thinking.
Right.
Yeah.
Right. The goal should be 0. 0 mortality, unrealistic.
It's
but that
not
still should
achievable,
be the
but that
goal.
should be the goal. It shouldn't be
0%
less than 7 or 20 or whatever
acute
it
renal
is.
failure, 0% stroke. But so what we have come to accept, that was my whole point, is unacceptable.
I can tell you a funny story. In the 80s, long before I was in the late 70s, early 80s, when I was still in my undergrad years, went to work at the hospital part-time, just being a phlebotomist, and you had to have your hepatitis B vaccination shots up to date. So back then, there was no artificial laboratory-derived vaccination for hepatitis B. It had to be derived from people who had hepatitis B.
Had to have
that was right around the big HIV craze was coming out. So I had my first shot. I think you had to wait 6 weeks later to get your second one. You're supposed to get a third one. Well, right about the time of the second one, the department put a paper out on the bulletin board that I think it was 0.7% or something like that of all people getting the hepatitis B vaccination were coming down with HIV.
Oh.
But it was 0.7%. And I remember somebody saying, well, that's pretty low. And somebody else said, but if you're one of the 0.7%, that's 100% for you. So what you're saying is if we have a 7% AKI and a 4% stroke rate, well, that's 100% if it happens to you.
Right.
So it doesn't matter that it's 7% and that's what everybody else is doing. There's still a lot of people that are being devastated by whatever that is.
Yeah, especially if you think that there's, 200,000 hearts done now, or 200. Yeah, it's 280. It's either 180,000 or 200.
It's been 200 something for a long time.
Yeah, somewhere around there. Yeah, no, I think it's 180,000.
Is that much?
It's gone down quite a bit. I mean, back in the day, I remember a time when it was over 700,000 cabbages a year. That's a lot. It's down to about, it's under 200,000 a year now in the United States. That's still, but that's still a lot when you start talking about 7%. That's a lot. Now, some, I understand, are unavoidable, but I think we should try, we as clinicians should do our level best to reduce that number for us, and our patients. We can't do a whole lot for somebody else's patients. And I think these discussions can help, but this is an individual, this is a practice technique. What matters to you? And some people, they are happy with what they're doing. I'm not. I think we can do better.
No, go ahead.
Go ahead.
On the few rare occasions where I actually do a case.
You did a case yesterday.
I know I did.
Yeah, you're good for another 6 months. I'll tell you a quick story. Back in 2015, I went to work at a place, and I won't mention the guy's name, but the guy was an excellent perfusionist. He was 15, 20 years, and he was just excellent. I learned a lot from him. And I go in there and watch him do a case, and he's behind the pump, and he's pacing, and I said, so-and-so, I won't tell his name, why don't you sit down and relax? No. And I always wonder, why is he on the edge of his seat? He's so nervous. Everything's going perfect. Everything he does was excellent. And after a while, I asked him, I said, so-and-so, I said, why are you so, nervous behind the pump? He says, I'll never forget what he said. He says, I try to run the perfect case every day. And he didn't even care if it was within his control or not. If the surgeon so much as reached back and made a comment about something, to him that was an imperfect case. And he had it in his mind that he wanted to run the perfect case every day. And I just thought that was so interesting, because what you just said a minute ago, Joe, is we kind of go in every day and we're comfortable with what we're doing, and so we do it. And he just stood out to me that it didn't matter that he'd been doing this as long as he had. It didn't matter that he really knew about as much as you could probably know and do, and he was still just paranoid and dedicated to somehow doing everything perfect every day, which is a big task because you can't do it.
That's right. But I think you have to try.
Yeah,
we have to try. So I've got a comment here from Franklin O'Dari. Discussion around metabolic acidosis and safe use of bicarb in view of striving for adequate perfusion while meeting the surgeon's dynamic flow requests, causing stages of tissue hypoperfusion, underperfusion, and hyper or luxurious perfusion on bypass. So you want to talk about that? Let's talk about bicarb. What do we all think about bicarb? It's not a substitute for good perfusion.
Oh no, it's by
but
no means.
It's certainly so Franklin. I think Dodell, go ahead.
I'm a big proponent of it. I give a lot.
You do.
I do, because we're using Del Nido. We have anaerobic metabolism going on, so I don't know what it is.
Where? The heart?
With Del Nido, because it's anaerobic. There's lack of the blood substitute in the cardioplegia.
You're saying because of the 5-to-1 ratio?
Yeah, it's more. It's a
Instead
1
of
to
4 to
4.
1,
It's,
or however you want it. It's
a
more
1 to 4. There's more crystalloid
Yeah.
than there is
Blood. Whereas,
Right. I understood that, but
So
I
I have
thought
less
that-
of a buffer with the crystalloid.
So how do you know you're having myocardial anaerobic? Because when you take the cross clamp off, you see a spike?
I
in
don't
your-
see
in
a
your-
spike, but you remember, I don't know, there was a study back in the 80s about talking about myocardial pH and how low it is in an ischemic state. So when you take that cross clamp off, if I create a little more of a metabolic alkalosis, I can maybe counteract some of that stuff. Kind of like how, you get leg ischemia from, what is it, the Impella or something like that, or a large catheter up there. You're going to get a release of some nasty stuff. So if you maybe pre-treat it or do something like that.
yeah, I wouldn't think. I mean, I don't know. I'm just trying to think.
But
It's
my
hard
heart's
for me
come
to
back. My
imagine
heart's
that-
come back a
Yeah,
little
they
nicer.
come back. I guess there's probably some. I imagine there would be. Yeah, I don't know. It's a good question. I would think we'd need to measure, put a coronary sinus catheter in, and upon release of the cross clamp reperfusion, measure the lactate level.
Oh,
or the
there's studies that have
immediate
done
lactate.
that. There's when we came out with when they came out with the coronary sinus, retrograde perfusion, people were doing that. They were like, leave it in, let's take a sample, and the blood is pretty deleterious the first 30 seconds or so.
Wow.
And one thing's very important, as you mentioned acidosis, and I was doing this research as I talk about lactates in almost every one of these studies. One thing people need to not forget is that the cells and the tissues detest acidosis. They do not function well. They will do everything they can to not be acidotic, and so anything we can do, cellular function, enzyme function, everything becomes dysfunctional, and even the modest amount of acidosis on a cellular level.
Really?
Yeah, and that's why if you ever notice, if you have a patient's metabolically alkalotic, we had one the other day in the unit, 7.57, and CO2 was low, and it was just a metabolic alkalosis, and I don't think that's very well understood. In fact, we had top physicians doing grand rounds, and I asked one of them, I said, do we understand why this patient would be in metabolic alkalosis? And he looked at me and said, nope. I said, you're not going to do anything about it, right? I mean, you're not going to give the patient acid, and I said, acid-based product, are you? He said, nope. Well, but when a patient's acidotic, and I mean even below 7.35 or even that range, the cells, if you look at the studies, do not want, that's why we have so much buffer systems in the body. We have so many buffer systems in the body to prevent acidosis, right? And so, it's important that we don't allow our patients to get acidotic. And then if they do, I'm not sure, was this question focusing on deleterious effects of giving bicarb?
Yeah, so is there any downside to bicarb administration? Is it So I think two parts to the question. I'm going to try to interpret it, but so the first one is, just basically dealing with metabolic acidosis. I think you answered that in saying that acidosis is bad. The cells detest it. So giving bicarb in that case is, appropriate. And you give bicarb generously, and you're not concerned about it. Metabolic alkalosis is not the issue, but dealing with the cause, the root cause of the acidosis, which is the surgeon is saying, you got to turn your flow down. I can't see. The heart's too full. Whatever it is, dealing with that and treating the subsequent acidosis secondary to hypoperfusion, how does that marry together? Does that benefit or does it not benefit? Because the acidosis, of course, if we shift our oxyhemoglobin dissociation curve to the left, vis-a-vis, you're going to release more oxygen more quickly to the tissue, so you improve tissue oxygenation in acidosis with hypoperfusion. So if you correct it, then you're going to go the other direction.
Of course.
And you make the affinity for oxygen, the hemoglobin have a higher affinity for oxygen. You don't release it as readily. So there's our dilemma now.
But rarely do I flow underneath like 2 liters.
Right.
Or excuse me, that's cardiac index of 2. I mean, if you look at
right,
my
but
charts.
are you delivering above 262 milliliters, index of 262?
Above 272.
272.
Oh, so you already did the math. I never go below 272.
I always do it.
But I think that's
Over
great
272,
that
or
we.
very
I
close
mean,
to.
I've already learned something that I can take with me on this on today, and that's I haven't not measured DO2 routinely, and I don't know why.
You know, is there an app? And I should have researched in my research.
Yeah.
There ought to be an
There
app where
may
all you
be.
have to
That's
do
what I
is
was
thinking.
plug
There
in
may
the BSA.
There may be.
That's going to stay the
Magic?
same. And then all you have to do now is hit
Where's
hemoglobin
Magic?
and get a DO2 and hemoglobin, because that's the
Right.
variable left, right?
Right.
Because you know your
If you know
your
your-
PO2 is going to be a decent amount, and
Yeah.
it's only
Yeah.
it's only 3% of the equation anyway, and your PO2 is going to stay good. Your saturation, put in 1.0, 100% for simplicity, or 0.99 if you want, and all you do is say hemoglobin 7, what's my DO2, and get 4 or 5 of them, and right there, without having a fancy machine that hooked up
Right.
to your, you know what I mean? Because these guys have shown that if you can keep above these 3 parameters, you're not going to be producing any lactate or anaerobic metabolism almost anywhere in the body. And I always found it
Well,
interesting.
the body doesn't like lactate either.
Yeah.
Well, that's
Especially
same
the
thing.
lungs.
Yeah.
Lungs hate it.
You know what's to me funny about perfusion is
Is there an app? That's what we want to know.
Is there an app?
Is there just? He doesn't know.
The question was, is there an app to easily measure DO2?
DO2. There will be. Excellent.
You guys can make one. So don't you ever think to yourself, you're sitting behind a pump and you've got this everything going on, and the arterial line goes up onto the table and basically disappears behind the PA.
Sure.
And basically it disappears, and you basically sit back and hope that on a micro level, on a regional level, that the body's just going to be perfused perfectly everywhere. And that's not what's happening.
Right.
And that's why if you're monitoring, there could be regional areas of anaerobic metabolism. There could be micro areas. There could be macro. There could be places being overperfused, underperfused. And so without monitoring some of these things, you're just saying, oh, my venous blood gas is coming back great. As you can see, the SVO2 was not really an indicator
Right.
of producing.
And I think for our routine coronaries, that's generally not that big of a problem. But I think in the ICU setting, which we spend a lot of time in, do we even think about capillary bridges like we used to? We used to think about, you probably learned that in school.
Right.
How, perfusion deficits that are occurring at the microcapillary level, where you have this perfusion defect that occurs, and you can actually see where the flow is. They do it with these sublingual. I told you about those before. These things you can look in at the microcirculation under the tongue and actually see, instead of the flow going through, you can see it sludging and stagnating and not flowing properly in a very hyperdynamic cardiac environment. They're septic and their heart's just pounding and their blood pressure's tanked and all these things are happening, and you think their cardiac output is 20. But at the capillary level, it's barely moving. It's not working right. And so I think those are kind of, that's where these things I think really apply. I think for our routine coronaries, it's probably fairly uncommon, unless you have some kind of, problem with the position of the cannula or something like that, to have a regional deficit. Although, I don't know, we have pulsatile flow. You talk to Dr. Cohn at Texas Heart, and he'll tell you, we capillaries are continuous perfusion, continuous flow, and there's a whole bunch of patients out there walking around with ventricular assist devices or artificial hearts that are continuous flow. So, do you really need a pulse?
Well, I think we have to talk about it a little bit differently. When you go on pump and you cool a little bit, even if it's down to 34, 35, or if you still go down to 28 or 30, when you cool, you're going to have vasoconstriction of the capillaries, and shunting is going to happen. How many times have you been rewarming or watched somebody rewarm and their SVO2s drop? And the perfusion will say to you, well, of course it's dropping, my metabolism is picking up. It's not going to pick up that much that fast. What's happening is you're rewarming, and all these clamped down capillaries that have begin tissue pore perfusion are now opening up, and you're getting a dump.
Yep.
That should tell you if you're rewarming and your sats were 80 when you were 30 degrees, and now they're 68 because you're up 3 or 4 degrees higher. You're having an opening of the capillaries that were constricted because you cooled or maybe gave NO2, and now they're opening, and that acidotic blood and desaturated blood is now coming back into the system. That's what rewarming is showing you. And you are having some increase in metabolism. But, to me, you're also increasing your flow, right? We have a 1.8 at low and 2.2 and 2.4. So you're telling me that the metabolism went up, but I see that you've turned your flow up too. But yet your SVO2 is still a lot lower than it was. So I think when you see that, you have to think to yourself, wow, when I was cold, even if you weren't monitoring all these things, it's showing you, the body's telling you, I was not really getting a lot of, there was regions of tissue that weren't getting perfused while you were at that colder temperature.
Very good. Okay, well, let's go around the table and get some final thoughts. I think we're over time to make up for yesterday. That's okay. We got to make up for yesterday. Yeah, so we're going to start over here. Rodell, final thoughts for the day.
I really think, this simplified, flow calculation is excellent. That is absolutely great. I think everybody should calculate this.
Everybody should be calculating.
It's interesting. I always flow at a, 2.4, that kind of thing. And I do, a small calculation, and I will come down every once in a while. But I think we should do this every single case, or just find a simple hemoglobin like 7, 8, and 9. That's it's really easy. It's really easy, and I can explain to my surgeon, hey, Dr. So-and-so, I am flowing at my 272 mLs. I am getting this guy or gal the correct flow, so we don't have this.
Right. I can't get down any further. I'm at the threshold. I'm at the threshold that below this is going to create problems.
Yeah. Move your cannula.
Can you not just can you see? Can you deal with this?
Yeah. Can you deal with this? Or hey, maybe you have to reposition your cannula because I need to flow this. I have concrete evidence to say like, hey, I need to do this. But you need to help me with my cannula. Or I need to do this. This is what's going on.
If your surgeon's evidence-based, you can really argue that well.
Oh yeah,
now it's
and
outside.
We have a couple.
Yeah, that's good.
They're only evidence-based until they can't see.
Then again, it all goes out the window.
Exactly.
I would comment back on the bicarb, giving bicarb. I would come down on the side that if you were having acidosis, you need two things. You need to treat it because you need to get the tissues out of acidosis. Then you need to find out why. You're band-aiding. It's a band-aid to give bicarb because whatever's causing it, probably still causing it. So I would be in favor of giving bicarb, getting yourself out of the acidotic range and getting the tissues and cells more happy, functioning well, and then see why you're causing acidosis. See if you can fix that.
Yeah, get out of the 8 ball.
You do have to be concerned, obviously, with a lot of bicarb, but sodium will go up.
Of course.
But that's a different issue. Ms. Sparacino?
Well, I think these talks have been really interesting because I'll admit I haven't thought as much about the kidney as I should have. And I've had a lot of kidney education in the past 3 or 4 months. And I wonder how many other people really are thinking about that. Just with your neo talk alone. So focused on one particular thing, and did I have urine at the end of the case? That's it. That's all the kidney that you thought about.
I've always said that I think the kidney is one of the most underappreciated organs in cardiac surgery. I've said that many times, and it's and it's something that I'm sort of into it, because I've got the CRRT thing going and this and that, whatever. But I've been looking at this in the organ crosstalk. John, you talked about that. All of these things, I think that. Are kind of touched on in school,
a little bit.
We forget about them,
Well, when you get out into practice,
right?
What do you have to do that? You've given us something to kind of look at for that, but when you get out there, what do you have?
Participating more in these kinds of programs. Everybody getting involved. Right, exactly. You know, we all need to get involved. That's what I'm trying. Yeah, that's my message for the day is what?
Last comment on Facebook.
Oh, flow is king. Oh, Joe Greco says flow is king.
Flow is king.
Flow is king. Joe, you're right. Why didn't you call in though? Why didn't you just pick up the phone and call? Look, I got the phone. It's right here. The number's up on the screen, 347-694-4400. If you call within the next 5 minutes, you will receive a PerfWeb. There, no, you do it. Thank you. Excellent.
Thank you, Vanna.
That was excellent.
That's awesome.
Okay, so, or send me an email. Let me know. Let me know if you'd like to get involved, Joe. You and also Franklin and Mohana and who else is on here? Erickson, come on, guys, get involved. Send me an email. Do whatever you want to do. All right. Tomorrow we have Dr. Samir, Hani Samir, is going to come back, and you put the schedule. Oh, here, I got it right here. And he's going to be talking about the optimal vent settings for resting the lungs affected by ARDS. And that's going to be really good. And then John is going to be giving us a talk. I went out to Orlando and visited John at his hospital, and he showed me around his 18 ECMO patients, and I was like, I saw this one, and I was like, what in the, just look, dude, what the hell is going on in there? I don't think I've ever seen this before. And so we came up with this talk when VV ECMO is still not enough.
Wow.
And that's going to be a great, I'm looking forward to hearing this, because I already know the story, but I want to hear how you break this down. So Dr. Samir, and speaking of bicarbonate acidosis, we were talking about that lactate levels. The lungs hate it. You leave your lactate level elevated, 10, 11 like that, you're going into ARDS.
Guaranteed.
So your hyperlactatemia can be caused by something else, but that lactatemia is going to result in you going into ARDS and needing to be on ECMO. So you have got to treat that. You can't just leave that. That's a major, major problem. And bicarb does not fix like hyperlactatemia. You've got to clear the lactate. And that's why Z-Buff, CRRT, better perfusion, fixing the underlying perfusion deficit is so critically important. And it's easily cleared with dialysis and CRRT. Lactate's a very small molecule. It comes out quickly. Very easy to deal with. Okay, so we'll see you all tomorrow, and thank you all very much.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial, direct, and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the AutoLog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are three things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive two-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive two-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.